Picture this. You're on your clinical rotations, perhaps staring down a pathology report.
Or squinting at a slide at 2 a.m.
Yeah, exactly. Squinting at this slide that looks like a chaotic abstract painting in, pink and purple. Your medical board exams are looming, and you're just trying to figure out if this messy cluster of cells is a temporary adaptation, a benign growth, or, well, a lethal malignancy.
And the sheer volume of Latin and Greek terminology is basically designed to trip you up.
Oh, absolutely. It is a total diagnostic minefield. Welcome to the deep dive, by the way. I mean, when you're looking at a broken bone on an X-ray, the pathology is binary.
Right, it's fractured or it isn't.
Yeah, but in cellular pathology, the lines between normal, reactive, and malignant are notoriously blurry. Exam writers love to exploit those blurry lines.
They really do. That's exactly what we're tackling today.
Yes, our mission today is to take that murky diagnostic landscape and build a razor-sharp clinical exam preparation toolkit.
A mental checklist, really.
Exactly. We're pulling high-yield material directly from a stack of USMLE tutoring and review slides by the Medical Association and Dr. Hammoudi. We are going to decode the histological stages of tumor growth, map out the mechanics of invasion.
Tear apart some very misleading tumor-like lesions, too.
Yes, and review the primary prevention strategies. And just to be clear, we're impartially reporting on these sources to help you prepare, focusing entirely on concepts that translate from the textbook to the wards.
Right, we're skipping the basic definitions you already know and jumping straight into the critical thresholds. Those moments where a cell fundamentally changes its identity.
Okay, so let's unpack this. Because before we can understand how a massive tumor behaves in a patient, we really have to track the microscopic journey of a single cell under stress.
Yeah, and the body is remarkably adaptable. When a tissue is exposed to a harsh environment, it doesn't just, immediately mutate into cancer.
Right.
The initial response is often an adaptive stress response. We call it metaplasia.
Metaplasia. So it's essentially a survival mechanism.
Precisely. Histologically, we're seeing the replacement of one fully differentiated adult cell type with a completely different, fully differentiated adult cell type.
Because the original cells just can't handle the local environmental stress, right?
Exactly. So the tissue just swaps them out for a cell type that can.
I always think of metaplasia like putting on a heavy winter parka when you walk into a blizzard. The cells realize their current uniform is going to get them killed, so they change.
That's a great way to visualize it.
And the most vital clinical takeaway of that parka analogy is that you can take the coat off. Metaplasia is completely reversible.
It is. And the classic board scenario demonstrating this reversibility is Barrett's esophagus.
Oh, yeah. The reflux patient.
Right. A patient presents with severe chronic acid reflux. The normal lining of the lower esophagus is stratified squamous epithelium.
Which is structurally designed to handle the mechanical friction of food, but
it is completely defenseless against hydrochloric acid.
So the tissue is getting bathed in stomach acid day after day. It has to adapt or ulcerate.
So it adapts. The stem cells reprogram themselves. That stratified squamous epithelium is replaced by simple columnar epithelium with goblet cells.
Which is the exact type of mucosa found in the intestines.
Exactly. Because intestinal tissue is naturally equipped to secrete mucus and handle high acidity, the tissue survives the stress.
But crucially, if you step in as the physician, prescribe a proton pump inhibitor and remove the acidic stressor,
that columnar tissue can actually revert right back to the normal squamous lining. Reversible.
Reversible. Awesome. But let's say the patient doesn't get treated, the reflux continues, the stress persists.
Right. Eventually, the tissue hits a breaking point, adaptation fails, and we enter the actual steps of neoplastic progression.
And the slides provide a very clean study mnemonic to track this sequence. It's NHDCIM. Normal, hyperplasia, dysplasia, carcinoma in situ, invasive, metastasis.
Memorizing that NHDCIM sequence is basically how you navigate any pathology question. You start at normal, which you know well.
Intact intercellular adhesion, basal to apical differentiation, standard nucleus to cytoplasm ratio, the N to C ratio.
Right. Then we hit H hyperplasia. The stress causes the cells to proliferate.
So we see an increased cell number.
Yeah, increased cell number, but the histology itself remains benign. The cells still look like the tissue they came from. And, just like metaplasia, hyperplasia is a reversible adaptive response.
Okay, so then the danger zone begins at D-dysplasia.
Right. Under the microscope, the architecture starts falling apart. We still have the increased cell number, but now the cells are physically larger.
The cellular orientation is lost, right?
Completely. And that N to C ratio begins to creep up. The tissue's disorganized and chaotic.
However, the vital distinction for the boards is that dysplasia, despite looking really concerning, is still a reversible process if the inciting factor is removed.
Yes. But then we reach the Rubicon, the letter C, carcinoma in situ.
Otherwise known as pre-invasive cancer. This is where the reversible adaptations end.
Once a cell reaches carcinoma in situ, the genetic mutations are locked in. The changes are strictly irreversible.
Irreversible.
Histologically, the N to C ratio spikes massively, and you see distinct nuclear changes, like severe chromatin clumping. The cells look entirely malignant.
But the defining cervical feature of carcinoma in situ, the reason it's literally called in situ or in place, is that the basement membrane remains entirely intact.
Right. The malignant cells are trapped inside the room. They haven't broken through the floorboards yet.
Which means they cannot metastasize. They don't have access to the blood vessels or lymphatics located in the underlying stroma.
Exactly. The leap from step 4 to step 5 invasive carcinoma requires the tumor to actively breach that basement membrane.
And the boards won't just ask you if the membrane is breached. They want to know the exact molecular mechanics of how the tumor pulls off the jailbreak.
Oh, they love testing this. It requires 3 highly testable molecular changes. Let's walk through that sequence.
Okay, step 1.
First, the tumor cells have to detach from one another. In normal epithelial tissue, cells are locked tightly together, largely by a protein called E-cadherin.
Right. Contact inhibition prevents them from moving freely.
To invade, the tumor heavily downregulates E-cadherin.
They let go of their neighbors, they're suddenly free-floating agents, but they still need traction to pull themselves through the tissue, right?
Yeah. To get that traction, they alter their surface receptors. They dramatically upregulate receptors for laminin and integrin.
Ah, so this allows them to grab onto the extracellular matrix proteins?
Exactly. They're essentially creating molecular handholds on the surrounding scaffolding.
So they've dropped the E-cadherin to break loose, they're using laminin and integrin receptors to grip the matrix, but they're still facing a physical barrier, the basement membrane.
Right.
How do they get through a dense wall of collagen?
They secrete enzymes to dissolve it. Specifically, the tumor cells upregulate matrix metalloproteinases.
Matrix metalloproteinase, I think of these as like molecular machetes.
That's a perfect analogy. These enzymes actively degrade the collagen and proteoglycans in the basement membrane, clearing a physical path for the tumor cells to squeeze through.
And enter the underlying stroma. So downregulate E-cadherin, upregulate laminin and integrin receptors, and deploy matrix metalloproteinases.
That 3-step invasion sequence is high-yield gold.
Definitely. And once they're through, they have access to the vasculature, setting the stage for step 6, metastasis.
Right. Now, once that irreversible threshold is crossed into full-blown malignancy, the tissue morphology can shift in dramatic ways.
And you will frequently be tested on 2 specific extremes of growth, anaplasia and desmoplasia.
Let's start with anaplasia. The sources describe it as a complete loss of structural and functional differentiation.
So the cells bear absolutely zero resemblance to the original tissue.
None. It is a hallmark of highly malignant, aggressive neoplasms. The term literally means backward formation.
They regress so far from their specialized function that they just become these chaotic replication machines.
Yeah, histologically, anaplastic tissue is a mess. You'll see extreme pleomorphism, meaning wild, unpredictable variations in the size and shape of the cells.
Because they've lost all regulatory control, they're just dividing furiously, which is why the mitotic rate is highly elevated.
You'll also see hyperchromasia. The nuclei stain intensely dark because they're packed with rapidly duplicating dense genetic material.
You might even spot bizarre tumor giant cells forming from chaotic, incomplete divisions, right?
Yes.
Yeah.
So anaplasia describes the wild behavior of the mutated tumor cells. Desmoplasia, on the other hand, describes the host's reaction to those cells.
Right. When an invasive carcinoma breaches the basement membrane and enters the stroma, the surrounding host tissue doesn't just sit there.
No, it mounts an intense, fibrous connective tissue response.
The body tries to wall off the invasion by laying down massive amounts of dense collagen and fibrous scar tissue around the growth.
Which fundamentally changes the clinical presentation. When you are conducting a physical exam, desmoplasia is what you're actually feeling when you palpate a malignant mass. That dense, fibrous response creates an incredibly hard, gritty texture.
So when a medical student feels a rock-hard nodule on a prostate exam or palpates a firm, fixed mass during a breast exam, They aren't necessarily feeling the tumor cells themselves.
No, they're feeling the desmoplastic reaction.
That's fascinating.
The high-yield clinical examples for desmoplasia are carcinoma of the prostate and Sierra's breast carcinoma. That rock-hard tactile sensation is a major clinical red flag.
Okay, so we have the chaotic anaplastic cells and the rock-hard desmoplastic walls. But what happens when you encounter a mass that looks like a tumor on imaging, grows like a tumor, but actually isn't a neoplasm at all?
Ah, you're walking into a classic exam trap. We need to differentiate between two benign, tumor-like malformations that masquerade as cancer, hamartomas and chorostomas.
Because they end in the suffix OMA, they sound like neoplasm.
But they are developmental anomalies.
Let's pull them apart. A hamartoma is defined as a mass composed of disorganized but fully mature specialized cells that are actually native to that anatomical site.
A prime clinical example is a pulmonary hamartoma. You might see a coin lesion on a chest X-ray. When biopsied, it's just a disorganized jumble of normal lung cartilage, bronchial epithelium, and fat.
Right. And another massive high-yield case is a cardiac rhabdomyoma.
Oh, definitely. The cardiac rhabdomyoma is a dense one for the boards. It is the most common primary cardiac tumor in the pediatric population.
It's frequently detected in utero on ultrasound, and it has a profound association with tuberous sclerosis.
Yes, if an exam question presents a pediatric patient with a cardiac mass and signs of tuberous sclerosis like ash leaf spots or seizures, you are looking at a hamartoma.
Okay, then we have the choristoma. A choristoma is an ectopic rest of normal cells located in completely the wrong anatomical location.
The tissue is perfectly organized and benign, but it is displaced.
Displaced.
For example, a pathologist might find a nodule in the wall of the stomach or the liver that turns out to be a pancreatic choristoma.
Literally a fully functioning normal chunk of pancreatic tissue sitting in the GI tract.
Exactly.
All right.
Another common example is endometriosis, where normal endometrial tissue grows outside the uterine cavity.
You know, the definitions can get tangled in your head during a long exam, so I like to visualize it using a house analogy.
Let's hear it.
Okay, imagine you walk into your own bedroom. It has all the right furniture, the bed, the dresser, your clothes, but everything is violently thrown together in a massive pile in the center of the room.
A complete mess, but it's all your native stuff.
Exactly. That is a hamartoma.
The native elements are present, but the structural organization is lost.
Right. Now imagine you walk out of your house, look across the street, and see your bedroom perfectly reconstructed, bed made, clothes folded, sitting in the middle of your neighbor's front yard.
The organization is perfect, the tissue is normal, but it's in an entirely ectopic, incorrect location.
That is a choristoma.
Native but disorganized versus perfectly organized but displaced. Making that clinical distinction is critical because it dictates patient care.
Because if you misdiagnose a benign hamartoma or choristoma as a malignant neoplasm,
You might subject a patient to a radical surgical resection or chemotherapy that they simply do not need.
which transitions us perfectly into clinical management and primary prevention modalities. Because once we map out how to identify these cellular changes, the next logical question for a physician is how we prevent patients from ever reaching that irreversible carcinoma in situ threshold.
To understand prevention, we need to quickly anchor ourselves with the epidemiological realities.
Right.
The incidence of cancer versus the mortality of cancer present two very different pictures.
Yeah, the most common tumor across the board is skin neoplasms. But when we strip away the skin and look at internal organs, the incidence breaks down like this. In men, prostate is number 1 at 32%, followed by lung at 16%, and colorectal at 12%.
And in women, breast is the leader at 32%, with lung at 13% and colorectal at 13%.
Those are the incidence rates. But when we look at the leading cause of cancer-related mortality, lung cancer completely dominates the statistics.
It is responsible for roughly 33% of cancer deaths in men and 23% in women. It is vastly more lethal than prostate or breast cancer.
And because lung cancer is the undisputed leader in mortality, the single most critical primary prevention modality in the United States, the intervention that saves the most lives, is smoking cessation.
Yes. The sources flag smoking as the #1 contributory factor for cancer deaths. Lifestyle modifications carry immense weight here.
Alongside smoking cessation, patients significantly reduce their risk by increasing dietary fiber, decreasing saturated fat intake, and limiting alcohol consumption.
Body weight is also a massive, often under-discussed factor. The slides note that being overweight is associated with a staggering 50% increase in cancer risk.
A 50% increase. We spend so much time on the molecular pathways, but managing a patient's weight and smoking habits remains the frontline defense.
Absolutely. However, the slides also dive into pharmacologic prevention, where we actively use medications to alter a patient's risk profile.
A simple, widely accessible example is aspirin. Daily aspirin use has been demonstrably shown to decrease the incidence of gastrointestinal malignancies.
Specifically esophageal, stomach, and colorectal cancers.
But the heavy hitter for the boards, the drug with a mechanism you have to know cold, is tamoxifen.
Right. We use tamoxifen to reduce the risk of a second primary malignancy in breast cancer patients.
The pharmacology of tamoxifen is fascinating because it's a SERM, a selective estrogen receptor modulator.
The term selective means its effect completely changes depending on the tissue environment.
In breast tissue, tamoxifen acts as a strict estrogen receptor antagonist, right?
Yes. It blocks estrogen from binding, effectively starving estrogen-dependent breast cancer cells.
It's brilliant for the breast, but what happens when that same drug reaches the uterus?
In the endometrium, the mechanism flips. Tamoxifen acts as a partial agonist. It actively stimulates the estrogen receptors in the uterine lining.
Wow. So while you're successfully suppressing breast cancer, you're simultaneously driving endometrial proliferation.
Which actively increases the patient's risk of developing endometrial cancer.
It's a profound clinical trade-off. And because it modulates systemic estrogen receptors, you're also inducing severe hot flashes and significantly increasing the risk of thromboembolic events.
Yeah, you have to monitor these patients constantly for deep vein thrombosis and pulmonary embolisms.
Okay, the final pharmacological agent we need to dissect is isotretinoin, known commercially as Accutane or retinoic acid.
In oncology, it's used to decrease leukoplakia, those precancerous white patches in the lungs and GI tract.
And it serves as a primary treatment for acute progranulocytic leukemia.
The mechanism relies on forcing cell differentiation. But isotretinoin comes with a massive multi-system side effect profile that will absolutely show up on your exams.
You have to know the burden you are placing on a patient when you prescribe this.
The side effects hit almost every system. Mucosally and dermatologically, patients suffer extreme dryness of the mouth, nose, throat, and anus.
They experience severe itching, hair thinning, and structural changes to their nails and skin, right?
Systemically, it triggers hypertriglyceridemia, meaning their lipid levels spike, alongside nausea and weight loss.
But the serious life-altering risks are what you really need to counsel a patient on. Isotretinoin can cause bone softening and brittleness, severe inflammation of the liver and pancreas, and the development of cataracts.
Psychologically, it carries a severe risk of depression and suicidal ideation. It can even induce strokes.
And paramount to all of this is its teratogenicity. Isotretinoin causes catastrophic birth defects.
The regulatory framework surrounding it is intense. Any patient capable of reproducing must be enrolled in the IPLDH program,
which is a strict clinical protocol requiring the continuous use of two separate, highly effective forms of birth control while on the medication, alongside regular pregnancy testing.
You don't just write a script for retinoic acid, you manage a comprehensive safety protocol.
Okay, we have navigated an incredible amount of pathology today. As you head back to your review books or onto the wards, let's lock in this mental checklist.
Track the cell's journey through the NHTCIM sequence.
Pinpoint the exact moment a reversible adaptation like dysplasia crosses the intact basement membrane to become an irreversible carcinoma in situ.
Remember the molecular machetes, the matrix metalloproteinases that allow the tumor to chew through that membrane, dropping E-cadherin and gripping lamin along the way.
Differentiate the rock-hard desmoplastic reaction you feel on a physical exam from the wild microscopic chaos of an anaplastic cell.
Don't fall for the OMA trap. Know whether you're looking at a disorganized native hamartoma or a perfectly displaced choristoma.
And master the dual nature mechanism of tamoxifen and the strict IPLDH protocol for isotretinoin.
You now have the framework to look at a complex clinical scenario and understand exactly what the tissue is doing, how it got there, and how to intervene.
But I want to leave you with one final, deeply provocative concept to mull over. The sources mention our host defenses, the fact that we have an active immune surveillance system.
Right. We have natural killer cells that can destroy tumors without prior sensitization.
We have armies of CD8 plus T cells and macrophages constantly patrolling the stroma for abnormal cells.
which presents an incredible paradox. We just spent 20 minutes discussing how loud and aggressive an invading tumor is.
It's mutating wildly, shedding surface proteins, and literally deploying enzymes to dissolve structural barriers. It's making a massive amount of molecular noise.
So if our immune system is mobilized to hunt down abnormal cells, how do the most advanced anaplastic tumors manage to survive the breach?
What hidden mechanisms, what cloaking devices do these highly mutated cells develop in that final step of metastasis to turn themselves completely invisible to our own security forces?
It is the ultimate question in cellular pathology and the frontier of modern oncology.
It reminds you that no matter how much we map out, the cell still has secrets. Thank you for joining us on this deep dive. Take this framework, crush your board questions, and most importantly, use it to see the bigger picture for your patients on the wards. We will catch you next time.